A very good evening to all of you present on today's session. I am Nishita from Clarinet. Welcome all of you on today's session, Carva, powered by SNO Madhya Pradesh. Clarinet is proud to be associated as a digital partner. Now, I am going to play a very short Clarinet's video. I would like to request all of you, please have a look. Thank you so much everyone for your patience watching. Thank you so much, everyone. Now, I would like to hand over the session to Miss Arya Sharma, ma'am. Ma'am, over to you. Please proceed.
Thank you so much, Nishita. A very hearty good evening to all the participants. Today, we, the students of SNO MP, are going to organize a case presentation competition. So, before beginning this competition, I would like to give an introduction about our organization. Student Network Organization is a network of medical students who work to promote health equity in education and healthcare through intercultural and multidisciplinary collaboration with the goal of universal health care construction. Here, we create space in order to strengthen students' interest regardless of their area of expertise. So, I am Arya Sharma, your moderator for today's case presentation competition. And now let's start the competition. Few things which I would like to clear out is that you will be given 10 minutes time to present your case. And at the end, you will be asked few questions related to your case. We have also sent your case presentation to our judges, but due to some emergency reasons, she was not able to come. So she has sent me a list of questions, which I will be asking you at the end of your case presentation. So without wasting any of the time, let's start. We have the first participant, Sakshi Kumari, fourth year MBBS student. Sakshi, are you there?
Yeah, I'm here. Am I audible?
Yes, you are audible.
Yeah, so when do I start? Can I start now?
Sakshi, your video is not visible. Okay, now it's visible. Yes, you can start.
Yeah, is it visible now?
Yeah,
Yeah,
you can.
so good evening, everyone. Good evening, everyone. I'm Sakshi Kumari, and I'm a fourth year MBBS student. Today, I'm going to be presenting a case of, next slide, please. A case of peripheral vascular disease secondary to CREST syndrome. So a female patient aged 48 years old who hailed from Chikmagalur was admitted in a hospital on 18 July 2022 with the chief complaints of blackish discoloration of fingers of the upper limb since 1 year, pain in the right and left feet since 2 months, and blackish discoloration of feet of right lower limb since 2 months. Next slide, please. So the history of presenting illness, the patient was apparently all right 1 year ago, and then she developed blackish discoloration of upper limb digits, which was insidious in onset, associated with loss of sensations and claudication of limb at rest, which was followed by artery amputation of both right and left index little fingers. And there was also pain in the right and left feet since 2 months. It was insidious in onset, aching in nature and continuous. It was also associated with claudication at rest. There was blackish discoloration of right foot since 2 months, which involved toes of right foot, followed by auto amputation of fifth toe of right foot. Next slide, please. There was history of patient's finger turning pale on exposure to cold and numbness, which was associated with tingling sensation. There was history of swelling of digits and joint stiffness, which was not associated with pain. There was history of difficulty in swallowing and weight loss. There was history of dry skin, especially in the areas of forearms and lower legs. There was no history of fainting, chest pain, abdominal pain, transient blackouts, or alteration in bladder and bowel movements. Next slide, please. Past history, family history was not significant. Personal history, the lady consumed mixed diet. The patient's appetite was decreased. However, the bowel and bladder habits were normal, and there was no socioelectric habits present. Next slide, please. General physical examination of the patient was normal. Her vitals were also normal. Next slide, please. A local examination. The patient was explained about the procedure and examined under adequate light exposure. Both the limbs were completely exposed from the level of anterior superior iliac spine, the tips of toe, and both the upper limbs were exposed from the level of acromion process till tip of the fingers. Inspection of right lower limb. Attitude of the leg was hanging down the bed. Fifth toe was amputated. There was black mummified appearance of the remaining toes with blackish discoloration of entire foot, the clear mark of demarcation. The leg below the knee showed thinning of skin, loss of hair, subcutaneous fat, and luster. The nail shows transverse ridges and brittle skin. Next slide, please. And the nails were brittle. And those on pain exposure to cold, thigh appear to be normal. Next slide, please. Next slide. Palpation of right lower leg. The left leg is cold compared to the right leg. Skin was pale and dry, and temperature was normal below the knee. There was irregularity of the digits present. Weakness toes were hard and shriveled, mummified appearance, tight alignment of toes, and loss of sensation with black discoloration of entire was present. Next slide, please. Palpation of the peripheral vessels. So on the right side of the body, the dorsal spirits will be palpated. Anterior tibial was not palpated. Posterior was also not palpated. Left side, the arteries were palpated. And right, and the upper limb, as we can see, radial.
I think Sakshi has left this meeting. Okay. So, yeah, we have our next participant, Mrilalini. Are you there?
Yeah, I'm here. Can you hear me?
Yes. Can you please turn on your video?
Yeah.
Okay.
Am I visible?
Yes, you are.
So I would like to apologize in the beginning. I'm inside a hospital, so if you hear anyone screaming or crying, my deepest apologies.
Okay, okay.
So let me know when I can start.
You can start now.
Okay. So to change the slides, do you have to like tell the present, like, or will they change it?
You have to tell her to change
Okay.
the slide.
Okay, thank you. Can you go to the first slide, please? Yeah. So a pleasant good evening to one all present here. I'm Dr. Mrinalini here to present a rare case of Mobius syndrome which we encountered in our hospital. I'd like to thank Dr. Soundarya ma'am for helping me through this journey. And I'd also like to thank SNO MP for giving us this opportunity. Can you go to the next slide, please? Mobius syndrome is a congenital, non-progressive, complete or partial, unilateral or bilateral facial nerve palsy with or without paralysis of the other cranial nerve and with multiple limb malformations such as brachydactyly or syndactyly, hypoplasia or agenesis of the brainstem nucleus with the absence or decreased number of muscle fibers has been reported to be the cause. Paul Julius Mobius, a German neurologist, first described this clinical entity of combined paralyses of the 6th and 7th cranial nerve in 1892. Next slide, please. We had a 10-year-old female who came to a hospital with chief complaints of inability to close the eyelids since birth and inability to close her lips and difficulty in phonation since early childhood. There's a history of dribbling of saliva and epiphora present. Her antenatal, natal, and postnatal periods were uneventful, and the child has been immunized as per age. The parents are unrelated and young at the time of conception. There's no history of any maternal drug intake. There's a history of delayed milestones in all 4 domains according to the mother, but she says that eventually she attained all the milestones by the age of 2. And there's history of feeding problem during infancy. There's no history of any hospitalization or physiotherapy given in the past. The child is able to do her day-to-day activities by herself and performs well. But other 2 siblings are normal, and there's no history of similar illness in the family. Can I go to the next slide, please? On general examination, we saw that her motor, sensor, and cerebellar functions were normal. Her first, third, fourth, eighth, ninth, 10th, and 11th cranial nerves were normal. And head-to-foot examination revealed a simple incomplete brachysyndactyly. Can you go to the next page, please? A simple incomplete brachysyndactyly of the second, third, and fourth fingers, or with the first web contracture in her left hand, as shown in the picture. Can you go to the next slide, please? On ocular examination, we saw that her eyes were orthophoric with a 6/9 partial vision, not improving with pinholes bilaterally. She had lack of thalamus with adequate Bell's phenomenon and medial canthal tendon laxity. Her conjunctiva and cornea were normal with the normal anterior chamber. Her iris and pupil were normal with pupil reacting both to direct and indirect light reflex, and lens was clear. Can we go to the next slide, please? And her fundus was normal with presence of near reflex. Her color vision and field of vision were normal, and her snapback test was negative with a positive fluorescence dye disappearance test. Can you go to the next slide, please? Here we see her binocular extraocular movements, that is version movements. As you can see, she's able to elevate and depress her eye, but she's not able to look to either side, which is nothing but the horizontal gaze pattern. Can you go to the next slide? This is the duction movements or unilocular movements of her right eye. Here we can see she's able to elevate and depress her eye, but she's also able to adduct her eye. And she had intorsion was present, but she could not abduct her eye. So it says that her 6th cranial nerve is affected. Next slide, please. Similarly, when instructed to do so, she was able to elevate and depress her eye, and she was able to adduct her left eye, but she was not able to abduct her left eye. Can you go to the next slide, please? Yeah, and coming to the 7th cranial nerve, her motor component was affected, but her sensory component was intact. Next slide, please. Here we see lack of thalamus in both eyes with absence of wrinkling of forehead on when instructed to look up, and she had a absence of nasolabial fold on both sides, and she was not able to close her lips properly. Next slide, please. We started to investigate the case by taking an X-ray of the left hand, which revealed the presence of shortening of the middle phalanx of the 2nd, 3rd, and 4th fingers. Her echocardiogram and chest X-ray were normal, and her brain MRI was normal. Brainstem motor evoked potential was normal. Can you go to the next slide, please? This is the X-ray which shows the brachysyndactyly, that is shortening of the 2nd, 3rd, and 4th digit middle phalanxes. Next slide, please. And this is her brainstem motor potential, which was within normal range. Next slide, please. We started off by instructing the child to tape her eyelids closed during sleep, and she has been advised to use artificial tears regularly. Both the child and her parents have been informed to review if she develops any danger signs such as blurring of vision, photophobia, or redness. And she has been scheduled for corrective surgery of the brachysyndactyly. Next slide, please. My major differential diagnoses include Poland syndrome, Millet-Gueblet syndrome, Fovili syndrome, and Apert syndrome. Next, please. Although there are many theories regarding the etiology of Mobius syndrome, the exact etiology is unknown. There's a primary defect could be that there's a maldevelopment of the cranial nerve nucleus or a hypoplasia of the muscle fibers or a combination of both. An ischemic process due to a vascular insult around the 4th to 6th week of gestation could be the cause of all these limb deformities in Mobius syndrome. One of the life-threatening complications that a patient can develop is aspiration. Though our patient had feeding problems early in childhood, there's no history of any aspiration pneumonia and subsequent hospitalization. Next, please. I'd like to conclude by saying that, as with any other syndrome, early diagnosis and proper management significantly improves the quality of life of these children. As the affected children are not able to express their emotions, they often feel isolated and may develop psychological disturbances as they grow up. Our patient had two siblings, so she was a bit okay, but she still felt the main reasons they came in was because she felt lonely and that other kids wouldn't play with her. So, and because of the brachysyndactyly, a child may not be able to use their hand properly. But luckily for our patient, it was a left hand, so she was able to use her right hand properly, and she didn't really have any need for any help with her day-to-day activities. Next slide, please. These were my references. Next slide, please. Thank you.
Thank you so much. Now I would like to ask you a question. In your
Yeah, sure.
differential diagnosis slide, you have mentioned about the Poland syndrome. So what is Poland syndrome?
Poland syndrome is when they have an ipsilateral loss of the pectoral group of muscles, and they usually have some form of limb malformation, upper limb malformation in the same side, such as like brachydactyly or syndactyly. So initially, when we saw that, we thought it could be a Poland, but on thorough physical examination, there was no such atrophy or ablation of the pectoral muscles.
Okay. Can you please explain how the visual acuity is measured? Like with the help of what we measure visual acuity?
Visual what?
Can you please explain how the visual acuity is measured?
Yeah, for far vision, we use Snellen's chart. And since she was able to read, we used the alphabet chart. And we also used the e-chart just to make sure that, she wasn't saying it wrong because of her not being able to read the letters. And for near vision, we used a Jager's chart.
Okay, thank you so much, Nalanli. And now we will be continuing with Sakshi Kumari. Sakshi, are you there?
Yeah, I'm here.
Sakshi. Okay. Okay. Just a second. Nishita, Sakshi was left. Yeah.
Can you scroll down? Can you further down? Further down, please. Further down. Yeah, further. I've presented the screen. Yeah. Further down.
Ma'am, shall I keep these slides or go down?
No, down.
Is this okay?
Right, from here, yes.
Okay.
Yeah, so I'm sorry, everyone. There was some technical issues, so I got logged up from the Zoom meeting. Continuing with my presentation, palpation of lower limbs, the movements of joint at interstellar, mid-tarsal, and ankle joints were lost. At knee and hip joints, the movements were possible. Motor system examination revealed the tone and power of the muscles were normal. However, the bulk of the muscles were decreased. Next slide, please. Sensory examination, right, including angle were normal, particular reflex was on both sides. The reflex wouldn't be listed. Next slide, please. Examination of left lower limb, there was no ischemia, toes turned pale on exposure to folds, pseudodatally was present. Body test revealed marked pallor by degrees, capillary and venous filling time were prolonged. Those are the toes were present. Next slide, please. Examination of right and left upper limb, attitude of the limbs were flexed and kept over.
Arya ma'am, I think Miss Sakshi is not in this room, meeting room.
Yeah, she's not there.
So
Uh,
shall I stop the screen share?
yeah, you can. Okay. Dr. Amit Kumar Bose, are you there?
Yes, I'm there.
So, will you be able to present?
Yes, yes.
Okay.
4 5 minutes.
Okay.
Ma'am, do I need to share the slides or Dr. Amit Kumar will share?
Yes.
So I'm going to share, right, ma'am? Okay. I hope this is visible.
Yes, yes.
You can start.
Good evening. I'm Dr. Amit Kumar Bose from Department of General Surgery, IMS and Some Hospital, Bhubaneswar. Today I'll be presenting a rare clinical case report of recurrent angiolymphoid hyperplasia with eosinophilia of hand treated by intralesional steroids following surgical excision when a traditional therapy is still up to date. Next slide. Before going into the topic, let us know what is angiolymphoid hyperplasia with eosinophilia. It is a benign vascular proliferative disorder of unknown etiology. ALH can occur in all races, but it is reported more frequently in Asians. Young to middle-aged women are more commonly affected. The main differential diagnosis is Kimura disease, but the other disorders such as facial granuloma, insect reaction, cutaneous lymphoma, or sarcoidosis may intimate the clinical picture of HLE. Next slide. Inflammatory processes such as allergic reactions, traumas, arteriovenous shunting, elevated estrogen levels, autoimmune disorders are identified as a possible causes. We report a rare case of recurrent NLH with a new etiology who was successfully treated by intralesional steroids after several unsuccessful attempts with the other modalities. Next slide. A 21-year-old female nursing officer by profession came with erythematous, painful, and intense psoriatic nodal lesion over the front of the right forearm that had been going for 5 months. It was measuring about 3 into 3 centimeter. There is history of dust allergy and atopy, although family history was not significant. Next slide. These are the clinical images showing the progression of the disease. First image shows the erythematous nodular lesion over the right forearm, followed by the excisional biopsy was done of the lesion. Next slide. After the external biopsy, after 15 days, the relapse occurred, causing the recurrent multiple erythematous nodule over the around the excision site. And after attempting so many treatment modalities, then lastly we applied an intralesional corticosteroid that causes the complete remission of the lesion. Next slide. Patient has given the history of skin allergy test of drug amoxicillin and clavulanic acid at the same site 6 months back. Topical corticosteroid treatment had not led to any improvement. The lesion was surgical excised, as we have seen in the image, and biopsy was done, but relapsed promptly after 15 days with multiple painful and erythematous and pruritic nodular regions around the surgical site. Next slide. These are the histopathology slides showing the CD3 and CD28 positivity and predominant eosinophil forming aggregate and reactive follicles in the slide, which is suggestive of angiolymphoid hyperplasia with eosinophilia, which is a very rare finding. Next slide. On discussion, the term angiolymphoid hyperplasia with eosinophilia was first treated by Wells and Wimster. It is commonly associated with neither an elevated level of immunoglobulin or nor an eosinophilia. Next slide. These are the comparative difference between the ALH and Kimura disease, in which it is shows that Kimura disease occurs more commonly in males, subcutaneous tissue, and blood eosinophilia is common, which is not in ALH. Next slide. Surgical excision is the most commonly used one. 40% recurrence rate is there. But given the high recurrence rate, most micrographic surgery is also suggested. There are other treatment modalities including NDAC laser, electrodesiccation, anti-interleukin 15 antibody, including meprolizumab, was tried, but no successful treatment was there, according to the literature. Next slide. Conclusion and recommendation about this case is the new etiological or stimulating factor for ALG would be antibiotic skin allergy testing, as seen in our case. And we would like to highlight this case because it could encourage the treatment with intralesional corticosteroids, which is a traditional therapeutic approach that still offers the advantage of being simple to perform with similar results in terms of aesthetic result. Next slide. This warrants further research and efforts to find an effective cure and unified therapeutic approach. Most of this literature is present in the dermatology journals. However, surgery professionals who work with the disease that may involve the hands should also be attentive and consider the diagnosis of angiolymphatic hyperplasia with eosinophilia. Next slide. These are my references. Thank you so much.
Okay, so Dr. Amit, can you please explain that why there was recurrent multiple erythematous nodular lesions around the excision site?
Actually, patient had given a history of amoxicillin clavulanic skin sensitivity testing before giving IV drug. So from that area, that inflammatory reaction was developed that causes the recurrent development of that nodular lesion, erythematous nodular lesion. So maybe
Okay,
that response, antibiotic inflammatory response is there, still there. So it was treated successfully after the intralesional corticosteroids. But before that, we applied laser treatment, topical corticosteroids. Then we applied vitamin E isotretinoin, but it was not led to any improvement.
Okay, so you have mentioned about corticosteroids. So can you please name some corticosteroids and you have to tell the side effects of any one of the corticosteroid?
In this case, we have we injected a hydrocortisone and yes, hydrocortisone we injected in the lesion site.
Side effects?
Yes, other prednisolone side effect if you give intralesional on the lesion side, there is no systemic side effects. So you can definitely use that intralesional corticosteroids.
Okay, thank you so much, Dr. Amit.
Thank you. Thank you.
Next, we have Soumya. She is from Madhubani Medical College. Soumya, are you there? Soumya? I think she is not there. Sakshi, you were left with few of your slides, I guess.
Yeah, I'm really sorry. I mean, my internet has been, the connection is really bad. It's raining very heavily here, so I think that's the reason why
Okay,
I'm
will you
getting
be
disconnected
able
from
to
the
present
meeting
or not? Because I'm
because
not
of
able
that
to
reason.
see your video.
Yes, I will. Yeah, can you see it now?
No.
Yeah, I'd like to present it. I'm really sorry about it.
Just give me a minute, ma'am. I'm presenting it.
Yeah, can you open the presentation?
Is this visible now?
Yeah. So continuing with my presentation, examination of right and upper limbs. The attitude of the limb was flexed and kept over knees in sitting position. Skin appeared to be dry. Index and little fingers of both the limbs were amputated. So there was swelling of the fingers present. Skin over the fingers were thickened. And there was black mummified appearance of right and left index fingers. Capillary and venous refilling time prolonged. Next slide, please. Palpation, both the hands were cold, skin was pale, sclerotactyly was present, gangrenous digits were hard and shriveled, black mummified appearance, gangrenous of right and left index, right and left index fingers and little fingers were present, level loss of sensations. Next slide, please. Palpation of upper limbs. So the movements of the joints at intercarpal wrist joints were lost. Motor examination revealed decrease in the bulk of muscles. Next slide, please. Next slide. Sensory examination of upper limbs. crude and fine touch, pain temperature, sensations above the wrist were normal. Bicep reflex were present. Tricep reflex was present. Supinator reflex couldn't be elicited, and regional lymph node examination was normal. Systemic examination was also normal. Next slide, please. Provisional diagnosis: suspected peripheral vascular disease secondary to Crest syndrome. Differential diagnosis: atherosclerosis, polyarthritis nodosa, SLE, and Raynaud's diseases. Next slide, please. Next slide. Investigation: CBC, RBS, LFT, RHP, lipid profile, serum electrolytes of the patient was normal. Next slide, please. ANA was positive, RF was normal, anticentromere antibodies were present, and X-ray of the chest was normal, and CT angiography peripheral arms revealed aberrant origin of right subclavian artery, selective and complete blockade of radial artery. Final diagnosis: perivascular disease secondary to Crest syndrome. Next slide, please. Next slide, please. Treatment: amputation of the gangrenous ridges, pentoxifilin, clopidogrel, nicotinic acids were given, and tramadol with IV antibiotics. Bypass graft and high vascular surgery center was provided. Provided the collateral circulation was well established, and immunomodulators were given to the patient. Thank you.
Okay, thank you, Sakshi. You have presented about peripheral vascular diseases, right? So can you please tell me what are the causes of
Yes,
peripheral vascular diseases?
Yeah, so the most common causes are TAO, diabetes, atherosclerosis, then followed by hypertension, and then you have less common diseases like Raynaud's disease, Crest syndrome, Raynaud's disease, and then aberrant origin or polyarthritis nodosa can also cause SLE. These are some of the causes of peripheral vascular disease.
Okay, what is Raynaud's disease?
Raynaud's disease is basically when there is bilateral digital vasospasm is called Raynaud's disease. Episodic digital vasospasm of the fingers.
Okay. In your treatment part, you have mentioned about pentoxifilin, right? So can you please tell me
Yes,
which class of drug it belongs to and what are its side effects?
It is a vasodilator, right? It is and then well, the side effects I'm not really well, it's not actually used now. Like for peripheral vascular disease, we have more drugs like calcium channel blockers is what we prefer now. But in our government setup, it was not available, so we gave that to the patient. Speaking, I think hypotension is one of the side effects of pentoxifilin.
Okay.
Yeah, and the common causes like it can also cause nausea, vomiting, and hypotension.
Okay.
I mean, side effect.
Yeah. Thank you so much, Sakshi. It was a nice presentation. And now, do we have Soumya with us? And who is this with the name of Arya Sharma?
Ma'am, I cannot see in the name anyone has joined with the name of Soumya.
Yes, ma'am.
Oh,
Okay,
sorry. It's me, Ambikesh.
Oh,
It's me,
okay,
Ambikesh.
okay,
I guess
okay.
the name has been just changed, so I'll just make sure of it. It's me, Ambikesh.
So we are done with all the participants now.
Okay. Okay. Thank you, Sakshi. And thank you, Arya. But have we completed all the participants?
Yes, sir.
Okay. Okay, Arya.
So thank you so much, everyone. Thank you so much, Sakshi, Mridalini, Soumya, and Dr. Amit Kumar Bose for joining us today. And yeah, we are just ending the session.
Thank you so much, everyone. So, Arya ma'am, can we conclude close the session here?
Sure.
Thank you, everyone, for joining.